Welcome everyone to this installment of anesthesia training. Today I will be talking about arterial lines. So they go by many different names, so you might hear those thrown around every once in a while. Art lines can also be called A lines, invasive blood pressure monitoring, which can be abbreviated to IBP, or an arterial catheter. But for all intents and purposes, they are A lines to me. So I use these several times a week, and there are many different reasons why we can use them and why they might be useful compared to monitoring blood pressure or blood sampling through traditional methods. For example, like a central venous catheter or something like a blood pressure cuff. So why do I use art lines clinically? So there are a couple different reasons why I might end up using these on the clinic floor. If your patient has primary cardiorespiratory disease, this makes sense. If you have a patient whose heart doesn't function very well and you expect their contractility to be poor, their systolic blood pressure is going to be poor. And the best way to monitor that is going to be using a catheter that's sat in the actual artery instead of a cuff that's wrapped around it. If they have pulmonary disease, so if your patient has problems ventilating or oxygenating, having an arterial catheter in place is going to be very helpful because you can use that. And this ties into the next one for blood sampling. So you can check what their CO2 is. You can check what their oxygen is. Kind of what I just alluded to, you can also use arterial lines for blood sampling. Because the artery is a high pressure system, when you unclamp the arterial catheter and take a discard sample, you can then take a blood sample that you can run for anything. CBC chemistries, you can run eye stats, PCV-TPs, you can check glucose on your diabetic or your pediatric patients. If you have a patient getting chest surgery or a brachycephalic dog, you can check their CO2 and their O2 in their arterial blood, which is a great way to make treatment decisions for those patients that really need that help. If your patient is really sick, so if you have an animal that's dehydrated and it's lacking fluid, the systolic blood pressure is probably not going to be very good. Maybe also the heart rate is going to be very high. Having the arterial catheter in there is going to give you the best estimation, the most accurate blood pressure that you can possibly get. If you have a patient who is in high ASA status, so that means that anesthetizing them would be relatively more risky, or the type of disease they have becomes increasingly severe, that would be another indication to do that. If the blood pressure cuff isn't working, we all have those animals that have legs shaped like little wedges or triangles. So classic example would be a big brachycephalic dog or like a little sausage dog, a chondrodystrophic animal. If the leg is shaped like a wedge, sometimes we have to put on a really big cuff, and that will sometimes create artifact for us. We'll get something that's either artifactually low or artifactually high. The cuff is slipping off. It doesn't fit. So for those patients, that's a great way to find out what the blood pressure really is. And above all, it is the gold standard in blood pressure monitoring. The way that the cuff blood pressure or the oscillometric works is that it inflates to a certain pressure above the patient's blood pressure and gradually lets down, and then the mean is calculated and the other variables are measured. But if you have an arterial catheter, it's going to be sat in the artery. It is accurate, it is invasive, and it provides moment-to-moment information about the blood pressure. So if you really want to know, this is what you want to do. So what are they? How do they work? What kind of things would you need to be aware of? So there are a couple pieces of equipment that we would need to set up an art line on a dog or cat patient. The first thing that you're going to need is some type of pressure bag. So the reason why we need the pressure bag is because we need to constantly infuse a little bit of heparinized saline through the patient's arterial catheter. So we'll need a pressure bag. And then a 500 or a 1 liter bag of sodium chloride with some heparin in it. I usually put 3 units per mil of heparin into a bag of sodium chloride. And the reason why you want it heparinized is because this is going to hopefully prevent the arterial catheter from clotting. You pressurize the bag to about 250 to 300 millimeters of mercury. So basically the green bar on the pressure bag, okay? And what this will do is that over the course of an hour, it will give the patient about a ml of heparinized saline. You're not going to heparinize your cat. You're not going to heparinize your small dog. It's going to be okay. That's just the way it needs to work. So we have our hep saline bag, always labeled with when it was made, okay? I keep these open for usually a month, and then I throw them away. The next thing you're going to need is your extension set and your transducer. So it looks just like a fluid line initially. You've got your wheel and your clamp. We have all this tubing. And now we get to the interesting part. So this is the part of the arterial line called the transducer. So the transducer is basically the interface between the patient and the monitoring system. So there are different parts of the transducer. We've got a 3-way stopcock. We've got a flush system. So this little lever here will flush the catheter quickly. The bag will flush it gradually, but if you need to just give it like a little squeeze to prevent a clot from forming, this is a great way to do that. Sometimes they look like wings on an airplane, so you can also use that. And then we have a long, thin, non-distensible tubing that goes all the way down to the patient, and at this green end is where it attaches to the patient's arterial catheter. So those are the basic pieces of equipment that we would need to set up an art line. So, how would I go about doing this? The first thing you have to do is you have to place the catheter. So just get out your regular catheter supplies, just like you were doing for another animal, and you put it in an artery instead of a vein. So you can find arteries on many points on the dog or cat's body, and it really depends on which one feels the strongest to you, and also we have to think about patient selection. So there's the dorsal pedal, so the one running on top of the foot. It runs in the proximal third on the top of the dog's foot, and it runs diagonally. If you can feel it, you can throw it in there. That's a very common place. But there are many other places in case let's say you hit the artery and you can't feed the catheter, or the dog has a leg injury and it's bandaged and you can't place it. The middle auricular, so on the sides of the ear, we have veins, but in the middle, we have an artery. So that's a great choice, especially for like little dogs that have ears that stick up or animals where you mess up the foot. There are other places too, which I generally tend not to use, but if you had a 911 emergency, they would certainly be usable for a short period of time. There is an artery underneath the tongue. You can use that. It just becomes very difficult to secure the catheter. You can also use an artery underneath the metacarpus on the front leg, but because the leg flexes like this, it can be very difficult to prevent that catheter from being moved. The femoral artery. It would make sense, right? But the difficult thing about the femoral artery is that you have to tape a catheter in place. So especially with a leg being so big, that can be really challenging because that artery is so big and arteries are high pressure. If the catheter moves or falls out, we're going to have a bleeding problem. So you have all your equipment, you know where you can place them, and you place them just like a regular IV catheter. But there are a couple of differences. You're going to feel for a pulse. So you're going to feel where the pulse is and kind of create an imaginary line on the animal's skin and say, okay, this is kind of the path of the pulse. And what I want you to do is insert the catheter at the place where you feel the pulse most far away from the dog or cat, most distally. And the reason why that's a good idea is because just like a vein, you can move up if you mess up that end of the artery. So you go where you can feel the pulse, you get it into the artery. If you are in the artery, what is going to happen is that arterial blood's going to come out. So it will come up the catheter very quickly. It's going to be bright red. And when you remove your stylet after you've fed that into the artery, it's going to pulse. It's going to shoot out like this. That is how you know that you are in the artery. If you feed it into the vessel and it does not do that, like it just slowly drips out, it can mean one of two things. One, you could be in a vein. So veins are a low pressure system and lots of veins are located next to arteries. It's so common to hit the vein, not the artery. The other thing is the blood pressure is super, super low. So just think about that when you're placing them. So you would need that equipment, you know where to place them, and you know how to tell if you're in the artery. So what I would recommend as good practice is that when you're taping them and securing them is two main things. Number one, because this is an art line and not a venous catheter, you should label it. Label it with a piece of tape that says art line, label it with a drug added label, or we even make like proper arterial line stickers, but make sure there's a way we know that it's in an artery. And it also needs to say on the label, no drugs, only saline or only hepsaline. The reason why this is because we should not give drugs into arterial catheters ever. And the reason why that is because the animal will get cerebral ischemia, so parts of their brain might die, and that basically could mean maybe they go blind, maybe they have trouble moving post-op, maybe they have lasting brain damage. It's very rare, but it can happen. The other thing is that if you put drugs in here, they also tend to have arrhythmias. So one time I saw a student put antibiotic into an art line and the animal had a little bit of VTAC and then it came out of VTAC. So just so that we don't do that, label it very vigorously and make sure that we can tell right away it's an art line. Setup. So there's a couple things we need to do in order to get the information we want. So we want to measure blood pressure during surgery, or you want to measure blood pressure in the ICU. We're going to need to set up our catheter, we're going to need to set up our system and our monitor so that everything is ready for us to use this. So the very first thing that you're going to do is, let's say you've thrown in your catheter into your patient, you've taped it and you've labeled it. The first thing you're going to need to do is get your heparin saline into the pressurized bag, and you're going to need to pressurize the bag to 300 millimeters of mercury. So I would recommend seating the bag in the middle of the pressure bag, because if you put it at either end, sometimes it forms a bubble in the bag and it can explode, which is not a bad thing. It's just super inconvenient. So you want to pressurize it to the green bar in the bag. And just like we said, the purpose of this is that it flushes the catheter for you, so you don't need to do anything with it. So if you pressurize it and then you flip the stopcock on the bag up towards the bag, it will stay pressurized all day. You don't really need to worry about it super much. Sometimes it takes a while. We'll stop there for teaching purposes. So you can flip that up, and that way it's going to stay pressurized. You have to make sure that the wheel is unclamped. So sometimes you'll unclamp the wheel and the bag tubing will be very flattened. Just make sure you kind of plump that out so that way the fluid can actually get to the patient. You're going to hang this on some type of pole. You can shove it on your monitor. You can like put it on a shelf. It just needs to be hanging so that the fluid can flow. And what you're going to do is that next to the transducer, there's the cable. You're going to attach your cable to the cable on your monitor. And usually there will be a very satisfying click when you do this. And when the monitor senses that it's been attached, it's usually going to pull up a section on the monitor so that you can monitor the blood pressure. If it does not do that automatically, you will need to go to the waveforms and just say, I want more waveforms. So usually a monitor has 3 or 4. If you select 6 waveforms or multiple waveforms, you can make this happen and you can select it to be in there. So you attach the cable, you make sure that waveforms are properly displayed on the monitor, and then what you need to do is zero it. So what I mean when I say this is you've attached your cable, now we need to zero it. What I want you to do is set the transducer, so this guy, at the level of the patient's left atrium or somewhere around the level of their heart. And the reason why this is because blood pressure in animals and people is read with respect to atmospheric pressure. So we have to zero the system to atmospheric pressure. And here is how we do that. So on the monitor, you've set it up and you see the box where it's going to be measuring your invasive blood pressure. You're going to click on it and you're going to hit 0. And what you're going to do is that if the transducer looks like this, and the patient end is down here, and the bag end is up here, it's actually on the floor today, you're going to flip the stopcock towards the patient and open up this cap here so that the system is open to the environment and close to the patient. And you're going to zero the system, and it's probably going to take around 10 seconds for the equipment to show a 0 reading on the monitor, and that means your system is ready. So when that's ready, you're going to put a cap back on and flip the stopcock so that it's the other way around and open to the patient. And you can unclamp your arterial catheter and attach the end of the system. And if you've placed it in a vein, if you placed it in an artery and it hasn't fallen out and you've taped it properly, what you're going to see on the monitor are waveforms that represent the arterial blood pressure. And that's how you know. And then it's going to start displaying numbers, and the numbers might change moment by moment, or they might stay static for a couple of readings and then change. And this is how you know that you're in the artery and it's working. Now, there are a couple of important things to remember about zeroing the transducer. The very first thing is that all of this tubing needs to be filled with saline. So if there's an air bubble in there, it's really going to change the signal that is traveling from the patient up to the equipment, because the air bubble kind of halts everything, right? So you need to make sure that everything has saline in it. So make sure it's flushed through before you attach it to the patient. Make sure that the bag is properly pressurized. Everything needs to be unclamped. So you need to make sure the transducer is flipped the correct way. You need to make sure that the wheel, slider wheel on your bag is undone. And you also need to make sure that your arterial catheter, like the actual catheter itself, is unclamped as well. The other thing is that because we said pressure is read with respect to atmospheric pressure, there are a couple more like technology things you should know, which might be helpful. So the whole principle of arterial blood pressure is, let's say the patient heart contracts. So the heart contracts and arteries are elastic, right? They have elastic material inside of them. So what happens is that the energy from the contraction gets stored in the elastic wall of the artery. And this is important because that energy is going to travel from the heart to the aorta to all of the arteries in the body. And that energy is going to then be transmitted to fluid inside the tubing and come up here in the form of a pressure wave. The pressure wave is going to hit the transducer. And at this point, this is where the machine converts it to a number. Okay, so the signal needs to travel from the patient down all the arteries, up the tubing to the transducer. So it not only depends on blood pressure and your setup, but it also depends on fluid. So what this means is that you should set it at the level of the heart, but if it drops, if the transducer drops with respect to the patient's heart level, you are going to see a change in your blood pressure on the monitor. So if you drop the transducer and the heart is up here, the blood pressure is going to get higher. If you raise the transducer, the pressure is also going to change. It's probably going to get lower. So just make sure that if you move the patient, if you move the table at all, and your transducer is like glued to somewhere on your table, make sure that they stay together so you get the most accurate blood pressure. Okay, last couple of things that I want to talk about are just some general warnings that you should be aware of. So like I said before, never put drugs in art lines, please. We can minimize this by labeling them with bright tape. You can use red bed wrap or pink vet wrap to let people know that those are art lines. Only saline, only heparinized saline, sterile water for injection would also be acceptable, although it is less common. So we know that the artery is a high pressure system, right? Veins are a low pressure system. When you put a catheter in a vein, blood tends to drip out. When you put a catheter in an artery, it shoots out and it is pulsatile. So basically what this means is that if you put a catheter in and take the stylet out, if you just let it go, it's going to keep bleeding and bleeding and bleeding. So this is really important. When you're removing them, make sure you put a pressure bandage on them and leave them on there for at least 5 to 10 minutes. Ideally, an hour is great if you have an animal that's foot is going to tolerate that. And the reason why I like that is just because they'll tend to form hematomas around that area because it's such a high pressure system. So usually you'll pull out the catheter and the tape, it will start blowing up, and then you can put a bandage on it and usually it's totally fine. So those are the basics. They've got many different names. We can use them for sick patients. We can use them for healthy patients. If you need to blood sample animals, this is a great way to do that. That doesn't involve placing a central line or a PICC line, right? If the cuff doesn't work or you have an animal who the cuff is going to be very difficult to fit on, these are a great choice. And if you want the gold standard in blood pressure monitoring, this is the way to go. Accurate, invasive, moment to moment. And if they have arrhythmias or if they bleed, you're going to know right away. The stuff you'll need, the IV catheter, the extension set, the transducer, heparinized saline. We know we can place them in a variety of arteries. My favorite is the tail artery or the dorsal pedal. Everything else is just detail to me, so to speak. Tape it just like a regular catheter, but you got to label it. We talked about that. And you'll know if you're in the artery because it's going to pulse or flash bright red. Setup, you have to zero it, make sure it's at the level of the heart. If it drops above or below, we're going to change the blood pressure because it depends not only on kinetic energy from the heart, it depends on hydrostatic pressure. And if you detach it and you're all right and you have all the waveforms, you're going to see the pressure pop up and it's going to start giving you readings. No drugs, and make sure to put a pressure bandage on it. At a later point, I will have a video which describes how exactly you place them and how I tape them. It's important to remember that everyone places them a little bit differently and tapes them a little bit differently, but there will be a practical video coming up in not very long.